Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Okay, so here's how we're going to break this down. We'll start with the why, the treatment goals. Then we'll dive into the how, going through each major drug class, starting with the most important ones first, the statins, then niacin, the fibrates, and finally the bile acid binding resins.
So, first things first, before we even touch on a single drug, let's ask the most important question. What are we actually trying to accomplish here? What's the main goal? And here it is. This is the absolute key, the one thing you have to burn into your memory. The number one goal is lowering that bad cholesterol, the low-density lipoprotein cholesterol, or LDLC. Everything, I mean everything we do with these drugs comes back to that one single point.
Now, we always start with lifestyle changes, right? Diet, exercise, and they definitely help. But let's be real, they usually only get you a modest drop in LDL. For the big reductions that most patients need, you're going to have to reach for drug therapy. And when we talk about drugs for cholesterol, there's one class that is king of the hill, the HMG-CoA reductase inhibitors, or as everyone calls them, the statins.
Okay, so let's jump right into that cornerstone class. Seriously, if you're going to master just one of these drug groups for your exams, this is the one. It has to be the statins.
So, whether we're talking about a heavy hitter like atorvastatin or an older one like simvastatin, they all work the same way. The mechanism is really elegant. Imagine your liver as a factory that makes cholesterol, and it's running on an assembly line. Well, the enzyme HMG-CoA reductase is like the master power switch for that entire line. What statins do is they come in as a competitive inhibitor and just jam that switch. They shut it down, which grinds the whole cholesterol production process to a halt.
And check this out. This visual really shows you the genius of how this works. It's a chain reaction. So, first, the statin blocks that enzyme, right? So cholesterol levels inside the liver cell just tank. The cell panics a little. It says, hey, where did all my cholesterol go? And its response is to start building more LDL receptors. It then sends these new receptors up to the surface, and they act like little grappling hooks, snatching LDL cholesterol right out of the blood. It's this beautiful feedback loop that literally cleans the cholesterol out of your circulation.
Okay, let's talk pharmacokinetics. For statins, the liver's where all the action happens. They get broken down there, and then most of it gets dumped out through bile and into the gut. Now, this heavy dependence on the liver is a huge clinical point. It's exactly why you have to check liver function tests before you start someone on a statin. And it's also why you've got to be super careful about drug interactions, especially with anything that messes with those CYP450 liver enzymes.
And speaking of the liver, that leads us right into the adverse effects. Most people do fine on statins, but you're looking for two main things: elevated liver enzymes and myopathy, that's muscle pain. But the one you absolutely cannot miss, the big, scary, though thankfully rare one, is rhabdomyolysis. That's a massive breakdown of muscle, and it's a true medical emergency. It's the red flag side effect you have to know. All right, let's switch gears completely now and talk about niacin. If statins are the kings of lowering LDL, niacin is the specialist that's brought in for a totally different job.
Here's the one thing to remember about niacin. It is, hands down, the best drug we have for jacking up HDL-C, that good cholesterol. Yeah, it lowers LDL a little bit, but that's not its main gig. Its real claim to fame, the reason we use it, is its power to boost HDL.
And its mechanism is pretty cool, as you can see here. What niacin does is it goes to your fat cells, your adipose tissue, and it stops them from breaking down fat. This basically cuts off the supply of free fatty acids that are flowing to the liver. So you're essentially starving the liver of the raw materials it needs to make triglycerides and VLDL. No building blocks, no final product.
Okay, exam pearl alert. This is a classic question. The biggest, most famous side effect of niacin is this really intense skin flushing and itching, and it's all driven by prostaglandins. So, what's the clinical trick? It's simple. You have the patient take an aspirin about 30 minutes before their niacin dose. The aspirin blocks the prostaglandins and, poof! The flush is way, way less.
Okay, next up, the fibrates. Yet another class and another highly specialized tool for a very specific lipid problem.
Fibrates, like fenofibrate, are the go-to drugs when you're dealing with crazy high triglycerides. Their mechanism is totally different. They work by flipping a switch inside a cell's nucleus, a receptor called PPAR-alpha. Think of PPAR-alpha as the master controller for fat burning. When a fibrate activates it, it cranks up the production of an enzyme called lipoprotein lipase. This enzyme is like a pair of molecular scissors that just floats around in the blood, chopping up triglycerides. The result? A massive drop in triglyceride levels.
And for our last class, we've got something really different. Let's talk about the bile acid-binding resins, a group of drugs that do all their work without ever even getting absorbed into the body.
The way these work is actually kind of wild. It's totally indirect. So a resin like cholestyramine just hangs out in your gut. It grabs onto bile acids and holds on tight. This new, big complex can't be absorbed, so it just gets passed out of the body. Now the liver notices, hey, I'm losing all my bile acids, so it has to make more. And what's the main ingredient for bile acids? Cholesterol. So the liver starts pulling cholesterol from its own supply to make new bile acids. This makes the cholesterol levels inside the liver drop. And what happens then? Exactly what we saw with statins. The liver puts out more LDL receptors to grab more cholesterol from the blood. It's a clever way to trick the liver into cleaning up your LDL.
Since these drugs never leave the GI tract, their side effects are exactly what you'd expect. GI issues. We're talking constipation, bloating, that kind of stuff. But here's a really important clinical pearl on interactions. These resins are like sticky sponges. They're not picky. They can grab onto other drugs the patient is taking, like digoxin or warfarin, and prevent them from being absorbed too. So you have to be really careful about timing when you give these.
Okay, so we've got 4 very different drug classes, each with its own target, its own mechanism, its own side effects. This all leads to the big payoff question for your exams and for real life: how do you know which one to pick?
And this final slide, this is your money slide. This is the ultimate high-yield summary. It boils everything we just talked about down to a simple cheat sheet. Is the main problem high LDL? Your answer is statins, period. Is your patient's main issue a really low HDL? Niacin is going to be your best bet. And what if you're faced with sky-high triglycerides? You reach for the fibrates. If you can just lock in these primary uses, you'll be in fantastic shape for your exams, and you'll understand the core strategy behind treating hyperlipidemia.